Thank you all for being here. Many of you I've worked with before. My background, I started out as a pediatrician, and I came to Stanford and did all of my anesthesia training here and stayed. I thought at first, oh great, I can do adults and kids, but turns out I like pediatrics, so that's my specialty now, and that's the focus of my talk today is difficult airway management in these patients. My goals for the presentation are to share some data that I have on cases at our institution from the past 2 years and look for trends in patient characteristics, management practices, and outcomes, and also to benchmark that data to the Pediatric Difficult Intubation Registry, which is an international multi-center registry that's collecting data on difficult intubations in anesthesia cases. We're up to about 4,200 cases now that we have data on. And then also I'll reference published research that relates to what we're talking about and suggest opportunities for improved patient care. I have different icons. The one that's Stanford will be Stanford data, and the other one with just the red bar is data from the registry that I mentioned. My hope is that after our talk today, we'll all be more on the same page as far as having an understanding of our patients here at Packard, the cases, some of the difficulties we run into, specifically anticipated versus unanticipated difficult airway management, and how we can anticipate more of those cases, that you will be able to develop a shared plan for airway management with the anesthesia team prior to induction of anesthesia, and that we can analyze barriers to success for improved patient care and collaborate better to get better patient outcomes. These are a few patients that we took care of in the past year. As some of you will recognize some of them. I'm not going into the specific details of each case, but each patient represents something that I'm talking about today with regards to how we anticipate for these cases, how we prepare for them, how we manage them in the OR. So I'll be talking a little bit about these patients later on. I'd just like to mention, from my perspective, if the outcome is what's happening in the OR, there are so many things that hopefully have happened before we got there. And that's why I think it's really important to anticipate these cases, because the unanticipated ones are not going to have any of those other things done before you get into the OR. And we do try to pay attention. It may not seem like it, but we do try to pay attention to staffing for these cases, timing, where they're done, making sure we have all the equipment available, and that we collaborate with surgeons beforehand. Just a note on the data that I'm referencing today. So the cases that I look at are anesthesia cases across all services where they attempted to intubate. And of those, I have 81 complex airway notes just from the past year that I reviewed, and I have 137 cases in the prior 2 years that I reviewed. And then for each case, the majority of them get submitted to this multinational registry. There are a few that don't meet criteria. Usually those are age-based. The registry is only under 18 years. So occasionally we have an older patient that doesn't get into the registry and is not in my data set that I'm looking at here at Stanford. This just shows all the centers that are submitting data to this registry, and we're the one that's in red. So we're still on the smaller side as far as numbers. I think the top two are Boston Children's and CHOP. The registry was started at CHOP. But we're growing. We're definitely growing every year as far as the numbers that we're recording of difficult airway management. So how well do we do in anticipating the patient that's going to be difficult in the OR? The majority of pediatric difficult airways are predictable. There's as far as referenced literature that I looked at, one review of 1,000 cases, also from this registry, found that 80% of the cases had been identified prior as having a high likelihood of either a difficult mask or difficult intubation or both. Another study at the Hospital for Sick Children in Toronto, they looked at 22,700 cases. That was over 2 years. Their incidence of difficult intubations was 0.5%, and 1 in 5 of those were unanticipated. Interestingly, among those with prior general anesthetics, more than half of them, they said, did not have a history of difficult intubation, which doesn't quite seem in line with what we have here at our hospital. We have so many patients that are already flagged as potentially difficult based on a prior GA, a prior experience. But as far as the incidence that they have, the 0.5%, that's been fairly consistent for us. Most years we're between 0.2 and 0.5% of our cases end up being a difficult intubation. This shows our data as far as anticipated versus unanticipated. And you can see that our unanticipated rate was 11%. So the other study I referenced, they had about a 20% rate. So usually we're between 11 and 20%. But over the past 2 years, we've been 11% unanticipated. You can look at these kids and think about which you think might have been anticipated prior to going into the OR as either a difficult mask or a difficult laryngoscopy. The little guy in the middle did not have that helmet on when he first presented, but he did come in for a one suture craniosynostosis repair. So looking at our data, 73% of our kids did have an airway-related syndrome or diagnosis. And then we also have a bunch that have an unidentified syndrome. They've got some genetic abnormality, but it hasn't been named as a syndrome. And then, of course, as I mentioned, many of ours have a prior difficult intubation. And then I also look at the physical exam, and there's 2 questions there. There's, do they have an abnormal physical exam, and did we notice it and anticipate? And I find a very big discrepancy between the anesthesiologist's documented airway exam and then what they document in the intubation note. Often the airway exam pre-op will be nothing significant flagged, and then the intubation note will say difficult intubation because, and they'll go into micronathia or whatever they think was the cause. So our post-reporting of an abnormal physical exam is very high. It's 93%, but I suspect if I went through every case and looked at the pre-op note, there would be a big discrepancy there. And this shows that for 93%, the physical exam was abnormal. This is data from the multinational registry. For them, also majority abnormal physical exam. It was a smaller percentage there, about 80%, which correlates with their 20% unanticipated difficult intubations. So what are we thinking about as anesthesiologists when we approach these kids? We're thinking about aspiration risk. Whether the child has cardiopulmonary disease that places them at an increased risk for rapid desaturation or cardiovascular decompensation, reviewing prior intubation records, certainly flagging patients with craniofacial abnormalities or syndromes that are known to be associated with difficult airway management, the airway exam itself, and then whether we predict a difficult mask, a difficult laryngoscopy, or both. As you know, the causes can be broken down into anatomic or acquired. The reason what I wanted to point out here was just that in the pediatric patients, it's often difficult for us to get an accurate exam. We may not get the child to open their mouth, so we may not have an assessment of the oral aperture, the relative size of the tongue, any laryngeal or subglottic abnormalities, or any masses. In fact, this patient, she was going into the OR initially, was anticipated to be a difficult mask, but not really a difficult intubation because she had had multiple prior anesthetics that were grade 1 view, easy intubation. Unfortunately, though, she had laryngeal PTLD. She was extremely difficult to intubate, and she also had a URI, and she had some stridor, and so it was a confusing picture. Yeah.
So was the laryngeal PTLD known about prior to the intubation?
No.
Okay.
So that was discovered in the OR. Now, that I think was on the differential of someone's mind, but it wasn't diagnosed. They had tried to look on the floor, and she was completely uncooperative. Yeah. So just looking at the literature, flags for difficult mask ventilation would be anything that's going to make positioning difficult, so limited neck mobility, craniosynostosis, macrocephaly, meningocele, facial abnormalities that make it difficult to get a good seal, so anything that's asymmetric, such as Goldenhar, epidermolysis bullosa, also patients with obesity, OSA, or significant lung disease. And features that are validated in adults, but not necessarily in children, include facial hair, a BMI above 30, Mallampati 3 or 4, age above 57 or equal to, limited jaw protrusion, OSA, and abnormal neck anatomy. And if we look, how common is difficult mask ventilation? It's basically about 6% of pediatric cases as far as we know. This one study from Montreal Children's Hospital found a 6.6% in children aged 0 to 8 years old. And they didn't find an association between difficult mask ventilation and difficult intubation. The registry, very consistent with that study, has a 6.8% of that's difficult face mask ventilation, and then the 0.7% was patients that were impossible to ventilate. This is from LPCH. We had a 14.8% of cases were difficult to mask, and 1.5% were marked as impossible to mask. Talked about this patient a little bit already. A combination of several clinical features has been validated in adults as a sensitive predictor of difficult laryngoscopy. We talked about difficult mask, now we're talking about difficult laryngoscopy. Limited mouth opening, the Mallampati score of 3 or 4, as I mentioned, limited thyromental distance. But in pediatrics, for instance, the Mallampati score, you often cannot get an accurate score, especially 4 years and under, and it's not considered to be alone predictive in kids of that age. So point of this is that it's not predictive in isolation if you can even get a child to cooperate with the exam on that. These two babies, the one on the right was one of our patients. Clearly, unlike the other patient I presented, this patient was clearly an anticipated difficult mask and difficult intubation going into the OR. In addition to Pierre Robin, this child had a cervical stenosis, so we also had limited neck mobility, which made it very difficult to maintain inline stabilization and also do a rigid bronch at the same time. This child was actually, we started out, went straight with the LMA and the flexible intubating scope. In children under 1 year of age, that's been, at least in the studies that we have, has been more successful with a first attempt than a video laryngoscopy. But, and the the fiber was passed into the trachea, but we were never able to advance the tube. So ultimately, the child was actually intubated with video laryngoscopy, which is fairly unusual for his age and the features that he had. So looking at whether patients have a syndrome or an airway-related diagnosis, for our cases, see, 19.3% did not, and then all the other ones did. So as you know, we have a high rate. The 7.4 is, again, those unidentified. They have some sort of syndrome, but they don't have a name for it. And this is the registry data. They had 29% that were non-syndromics. That's out of 4,168 cases. So we basically have a higher percentage of syndromic cases here compared to the full registry. The number one was Pierre Robin, and the second one was Goldenhar. The third one was genetic abnormality of unknown significance. Those were our most common ones. And then there were other patients that had unknown syndromes. And that actually matches the registry as well. The multinationally, the top is Robin sequence, followed by Goldenhar. And then we have, the next one would be Treacher-Collins, and then Klippel-Feil, and EB, and Hurler syndrome. This child was actually completely unanticipated to be difficult mask or difficult laryngoscopy. He was otherwise healthy, just came in for one suture craniosynostosis. He had no prior anesthesia records. He ended up being an easy mask, but was a difficult laryngoscopy. So he was one of our unanticipated cases. Also looking at the age distribution, usually the younger patients tend to have more difficulty. I think that's possibly more weight related than age. But for us, it was more evenly distributed, but definitely the majority are under 10 years. 65% were under 10 years of age. The weight distribution, the median there, the red dot, is 23 kilos. So the scatter plot just shows that it's definitely the lower weight patients that we tend to have more difficulty managing. And these other slides are from the This is from the registry. They had two different subgroups. This was just because they changed the version that we were using to record this on RegCap. But you can see it's heavily weighted towards the lower weight distribution on that one, and same thing in the second group. Each of those groups had about 1,500 patients in them. Not only is it more common that we have difficulty managing the lower weight children, but they also have a higher rate of complications. So this is again from the registry, and the less than 10 kilo babies had 45% rate. The greater than 10 kilo babies had a 22.5% rate. Now those complications could be multiple complications listed for the same patient. So for instance, hypoxia and laryngospasm would be common. So that's partly why those numbers are so high. So the way I think about the approach to these cases is, first of all, if they're anticipated, we have algorithms to help guide planning for this. If they're unanticipated, they're higher risk, as we see when we show up, for instance, to the ER for an unanticipated difficult intubation. Also, there are different algorithms for adult versus pediatric, but the most, I think, referenced algorithm, at least in this country, among anesthesiologists, would be the American Society of Anesthesia difficult airway algorithm, and other ones are sort of offshoots based on that. So I'm just going to review a little bit of that. So if we look at this patient here, and we go through the 1, 2, and 3 of this algorithm, difficulty with cooperation or consent, difficult mask, difficult supraglottic airway placement, difficult laryngoscopy, difficult intubation, and difficult surgical airway access. These are all things that we should be thinking about before we get into the OR. Number 2 is something I think we need to focus on more, which is pursuing supplemental oxygenation during intubation attempts, and I'll talk about that a little bit more later. And then Number 3 is considering the risks and benefits of different management choices, such as awake versus sedated versus general anesthesia, starting with an invasive technique or a non-invasive technique, considering video-assisted laryngoscopy as an initial approach, and whether or not to preserve spontaneous ventilation is another area of debate for us. This shows you the pathway itself. It's pretty straightforward, actually. For peds, we're usually not in the awake intubation category. We're usually here. And it basically splits down to whether you can adequately ventilate or not. When you can no longer adequately ventilate, you're in the emergency pathway here. We also have a pediatric version of this here at Packard, which I'll talk about a little bit later. The difference is between this one and that version. But once you get down all the way to the bottom, you're basically considering surgical airway, waking up the patient, or other devices that you maybe have not tried. Our algorithm is accessible under Pre-operative clinical pathways in Epic. I'm not sure if you guys have the same view, but on the top right of my Epic, there's an icon there that will link you to all the pathways, and our algorithm is there, and we also have it on the anesthesia record. Let's see if I can pull that up here. So this is what it looks like. It's actually 3 pages long, so I'm not going to go over it all in detail, but I wanted to make the point that it's pretty comprehensive. It starts out with pre-induction, so any case that's anticipated, it goes over scheduling, considering things like, do we need an ICU bed reserved, trying to schedule a case before noon, making sure that the difficult airway card is in the room, identifying who's the ENT. Many of these cases are not, there might be a gen surg case or ortho, identifying who's actually in-house to call for assistance if needed, considering whether or not the patient needs to be evaluated for ECMO. So it's pretty comprehensive. And then we go into the second page is basically the OR management. Having multiple plans, A, B, C, and D for what you're going to do as far as attempts to intubate. Pre-oxygenating, it recommends maintaining oxygenation during attempts. It recommends maintaining spontaneous ventilation. You could debate that a little bit now. There is some evidence that paralysis can make ventilation easier in some cases. We now have Sugammadex for reversal, although that's not sort of a 100% solution if you're having trouble ventilating. But it definitely changes the picture. Other things that are in this algorithm that are not in the adult one are consideration for laryngospasm if there's difficulty ventilating, because that's so much more common in kids. And then in the third page, it talks about what you're going to do after the case. So plans for securing the tube or extubating in the OR, going to the ICU, all of those questions that need to be addressed.
Is this checklist actually consistently used by all the LPCH anesthesiologists?
No.
Well,
Yeah, it is in the ARC room, the anesthesia resource room, so all of the schedulers are aware of it. It is posted in many of the ORs, although not the new ones, but that is an ongoing issue, is just kind of reminding people about these things, yeah. So let's talk a little bit about what happens once we finally get into the OR, what we know about what happens here. So I'm going to talk about who's intubating these kids and how much experience they have, what is the preferred method, what are our success rates, how many attempts at laryngoscopy occur, how often do we use supplemental oxygenation, how often do we use paralysis, and what are some of the most common complications. I looked at anesthesia attendings to see who had been doing these cases, and essentially 66% of our attendings had at least one difficult airway they had managed in the past year. 12 attendings had 3 or more. So there is quite a range. And if you're not doing these cases, obviously you're going to be less facile when it comes time. So that's just something that we're going to be tracking. And then who the successful provider in actually most of these cases, 50% is the trainee, and that's the usually it's the anesthesia trainee, because being a teaching institution, we're trying to give them opportunities. And then about 37% were intubated by the attending anesthesiologist, and then 12.5% were intubated by otolaryngologist. Now, these do not include cases where the patient is intubated by the otolaryngologist as part of the surgery, like an airway surgery. These are all on induction. So these are mostly cases where we've called for your assistance if you intubated them. And then some of them we were already in the OR for an ENT case. Multiple attempts at direct laryngoscopy are associated with a higher failure rate and an increased incidence of complications, such as edema, bleeding, laryngospasm, or could convert into a stable situation into a can't ventilate, can't intubate. So that's why we're focused on that in the registry, and here, limiting those attempts. This shows the total number of intubation attempts for our cases in the past year, and the red line is 3. So everything on this side is less than 3, which is the goal, although 2 is even better. And then all of these cases here were 4 or more attempts. And I went and looked at these, and all of these cases were cases where you were either already in the room or you were called to assist. So those were the more difficult ones, obviously. This is showing that for us in the past 2 years at least, we have decreased the number of direct laryngoscopy attempts that we're doing. Let's see, the 2018 and 2017. So we had, if we look at just greater than 2 attempts, there were a lot in 2017. Basically, there were more in 2017 for greater than 2 and also for greater than 3. So we're doing better in 2018 than we were the prior year. And I think part of that is education, but part of that is also we have more tools now, and people will go directly to video laryngoscopy more frequently than previously, partly because it's available and partly because we're just transitioning in that direction. Alternatives to direct laryngoscopy are many. LMAs, of course, we have. Bougies we have, video laryngoscopy, we have the GlideScope and the Storz CMAC. We don't really have lighted stylets here or fiber optic stylets. We have the flexible fiber optic scopes from Storz. I think you have the Olympus, and now we actually just purchased a bunch of the Ambu scopes as well. And then combined techniques, which are becoming more common, such as a DL or video laryngoscopy with the flexible scope, and then a rigid bronch and the surgical airway. Most important is that we don't keep doing the same thing over and over without some adjustment. The studies that have looked at alternatives to direct laryngoscopy, basically video laryngoscopy definitely has a higher success rate than direct laryngoscopy, and that's in adults and kids, with one exception, which is that when they looked at infants less than 1 year, they're comparing video laryngoscopy and a flexible intubating scope. The flexible intubating scope was more successful on the first attempt than the video laryngoscopy. Also, I'm looking at complication rates between the fiber optic and the flexible scope and the video laryngoscope. The complications were the incidence of hypoxia was lower with the flexible intubating scope you use through the LMA with supplemental oxygen. I think that's probably more a function of supplemental oxygen than the actual equipment used. This shows the devices and first attempt success, and this is from the International Registry. The bluer one is the less than 10 kilo babies. So you can see the GlideScope, being the video laryngoscope, was a lower success rate than the fiber optic freehand or or the fiber optic through the LMA. But when you got to above 10 kilo patients, it was about the same, actually. The fiber optic and the glide scope, all about the same. All of these better than the direct laryngoscopy. So some of my colleagues have raised the question of, well, why don't we just put a video laryngoscope in every room and start with that? And maybe we will, and maybe that would be better for, probably be better for the patients, except for maybe the less than 1 year group. It does raise the question of, are we training people to do direct laryngoscopy anymore? And then also, I feel strongly that when we have a lot of patients that are easy video laryngoscopy, but a difficult direct laryngoscopy, and I feel pretty strongly that we still need to identify those as difficult intubations, especially for when they show up in other parts of the hospital where they're not used to using a video laryngoscope. This is from our data, and the glide scope is actually really popular among our group, but I think the CMAC will be catching up to that. You can see as far as like successful attempts, we're definitely moving away from direct laryngoscopy. That was a much less than all these other possibilities. What about paralytics? There's always a question of whether or not to paralyze. Traditional teaching for us was you're burning a bridge if you paralyze the patient. We do now have a rapid reversal for rocuronium at least, so that changed the picture a little bit on that. Looking at there was actually a recent study, it just came out in September from the Difficult Intubations Registry, where they looked at complications with regard to whether or not a paralytic was given, and the patients that were not paralyzed actually had a higher rate of what they call minor complications, such as hypoxia or laryngospasm, which is we often see in the OR. As far as serious, severe complications, the number was pretty small, and there was not a significant difference between the groups. It was only 1.9% of the cases. This just a brief note on Sugammadex reversal of rocuronium. It's recommended in the cannot intubate, cannot ventilate scenario. There are downsides. You could expect 3 to 4 minutes before neuromuscular function is returned. And even in that case, if you, for instance, have 4 twitches, but you're apneic from some other medication, such as propofol, the patient may not resume spontaneous ventilation as quickly as the Sugammadex actually works. There's a concern for reparalysis, so these patients have to be watched pretty closely afterwards. And also, there have been anaphylactic reactions associated with Sugammadex and rocuronium and the combination of the two. And then there are also case reports of laryngospasm on reversal as well. This is the actual ventilation technique. So this is from the registry, and the majority of these cases did get muscle relaxant, and these are all pediatric patients. So this is very different than what we're doing here at Packard, where the majority of our cases are not being given muscle relaxant. This shows our cases. So we only gave muscle relaxant to 33.8%, and the rest were no paralysis. Of the cases that did get paralysis, none of them were given Sugammadex. So it's out there, but it's not something we're using. It's in all of our carts, so it may get used this year. I also want to talk about apneic oxygenation, which should be the standard of care, and I don't mean just before intubation, I mean during intubation attempts. The data from the registry on this is pretty clear that it decreases hypoxia, and this just shows a couple of different ways to do it. We now have the Thrive in the OR now at Packard, and I think we should be using it more than we currently are, because it's been shown to prolong normal saturation in periods of apnea, basically, and in children and in adults. We don't know. It's The reliability of carbon dioxide clearance with Thrive is something that we need to know more about, but it's very helpful for preventing hypoxia. And it's like we have a study going on here at Stanford looking at patency of the airway with Thrive, which is, it looks like it is definitely helping to keep the airway open as well. We, in the anesthesia documentation, are doing a very poor job because all of these cases here were documented as no supplemental oxygen. So I'm not sure how much of that is poor documentation and how much of that is people not using it, but I'm definitely going to be encouraging my group to be using some form of supplemental oxygenation for all of these intubation attempts going forward. I did a little sub-look at the cases that were intubated by the otolaryngology attending, and that was 15 cases out of the past 2 years. These are all cases that, again, were intubated as part of the induction process of anesthesia. Only one of them was unanticipated. All of them except for 2 had some airway-related syndrome or diagnosis. The median age was 11.8, median weight 24.6 kilos. And they ranged many services: plastics, gen surge, neurosurgery, cardiac, GI, and dental. And some of them were also scheduled cases with otolaryngology. Intubation techniques included direct laryngoscopy, rigid bronch, flexible intubating scope alone, or in combination with direct laryngoscopy or an LMA. This is comparing our data from this year to the prior year, so the past 2 years. So we've had an increase in the number and incidence of difficult intubations, and that may be better capturing, better reporting, or it may be actually more cases. That's something that I can't say, but we are definitely recording more of these and getting more data on these. And we are also, you're expanding your services, which is bringing more of these patients in for us. There was a decrease in unanticipated difficult intubations, so we're doing a better job with that. It was 11%, but if you split the 2 years, it actually was a big difference. It was like 20% down to 11%. We're relying more on advanced equipment as opposed to just the standard direct laryngoscopy. And we haven't been able to decrease the total number of intubation attempts, but we are still working on that as well. This just shows the actual numbers of cases for three prior years, this being the most recent year. So you can see that we've grown a lot as far as just capturing these cases. And then this also shows the unanticipated difficult intubations going from here to here and down here. This shows the equipment that we're using and the change. The blue one is the more recent year. So we've increased use of the glide scope, the CMAC, the fiber, and the decreased direct laryngoscopy. The severe complications that we're recording in the registry would include severe airway trauma, pneumothorax, aspiration, cardiac arrest, death, and esophageal intubation with delayed recognition. We did not have any of those in these difficult airway cases. There have been aspiration events, but they weren't a difficult airway patient, and that's for here. We have a lot of the less severe complications, such as laryngospasm and hypoxia. As far as failed attempts, did we have any failed attempts? Not really, actually. We just had 2 cases that the attending decided to proceed with an LMA. And if we look at the registry, they had a rate of 1.6% of failed attempts. So I'm happy to say that at least for the past 2 years, we have been able to proceed successfully with all of these cases. And hopefully in the future, we can improve even further care for these kids. I think opportunities for improved care include, as I mentioned, anticipating the cases, improving collaboration and planning before we get in the OR, having a shared mental model, such as the algorithms I brought up, doing simulations, which Dr. Rama from the anesthesia group has started doing in the OR. Using supplemental oxygenation, we can definitely increase our use of that. Limiting our direct laryngoscopy attempts, and then just being aware of possibly the need for Sugammadex if we are in a cannot intubate, cannot ventilate scenario. And this shows one of our recent simulations. This was on airway fire with the use of laser. And here's Dr. Meister, and here's Patrick looking pretty cool there. And that's what I have for you today. Any questions?
How successful in pediatric LMA do you have in breaking laryngospasm if it occurs during the procedure? How successful can you break laryngospasm with LMA?
It's not successful. It's not going to help because the LMA, so you cannot ventilate with high pressures with the LMA, for one thing. So any kid with laryngospasm and an LMA, I'm going to be very quick to remove that LMA because we want to go straight to CPAP with high pressures. And then after that, it's deepening the anesthetic, usually with propofol, and if that fails, succinylcholine.
Follow-up question. Do you routinely topically anesthetize the cords before LMA?
No. And you may have other opinions about that. We don't. We're always concerned that topicalizing the cords itself is going to precipitate laryngospasm. So I'd say it's not the standard practice, but some people do like to use the LTA more frequently.
I mean, it seems to me that the major change has been the technology. Number one. Number two, the recognition of the use of teams, and then supported by the simulation. I mean, the whole, it seems to be evolving toward that trend. Besides the anesthesia team, who else should be learning how to use those glide scopes? I almost think that otolaryngology needs to know how to use this as well.
Yeah, you might want to. They're on, at least the difficult airway carts that are in the ICUs are also stocked with the CMAC video laryngoscope. We've had a very difficult time keeping those carts stocked. The blades just disappear. So we're getting a bunch of disposable blades now, which hopefully will not disappear as much. But they are there, and they're obviously in the OR as well. So.
Do you have pictures of the two scopes? What they look like?
I don't have a picture of those here. Sorry. Yeah.
Great presentation. I'm wondering, have you given this presentation to the entire Peds anesthesia group? And what did they think?
No, I gave this presentation. I gave all the data that I showed you that's specific to here. I gave that presentation about a month ago to the Pediatric Anesthesia Safety and Quality Group. But I think I'm going to suggest doing it as a division meeting as well. Yeah.
One last question in terms of the use of the CMAC. It's right there, fully ready to go?
Yeah, you just have to connect the blade to there's two options. There's a handheld, which has a little video screen on it, and you just have to connect the blade to that. And the other option is with the whole cart. There's a cable, so you can put it on the screen if you want.
Second question I had was, is the data that you presented include all the kids that are from the delivery room as well, difficult intubations in the exit type procedures or chaos type procedures?
It only includes difficult intubations associated with an anesthetic. It doesn't include OB, so if it's under OB, it won't. And that's a good point, actually. In doing this review, what I identified for us as an issue is we're not recording our out-of-OR intubations well. So that's going to be an initiative for this year because a lot of this, shall we say, sentinel events tend to occur out of the OR, in the ER, the ICUs. So, yeah.
All right, one question. You mentioned that in pediatric, Thrive literature that we haven't really been able to see the contribution of ventilation from Thrive, whereas
I'm talking about carbon dioxide.
Exactly, yeah. So what I'm saying is they've been basically, carbon dioxide has continued to rise with
Yeah.
Thrive. Whereas on the adult literature, there seems to be at least more benefit or more contribution in terms of decreasing carbon dioxide. We spontaneously ventilate a lot of our kids, but
Yeah.
it just seems like mechanistically they should share that same decrease in carbon dioxide. Where do you fall on that? Do you think that we just haven't done big enough studies yet, or do you think that kids are somehow not experiencing that same benefit like adults are?
These are adults that are apneic as well.
Yeah.
I think I can't think of a physiological reason why they should be different. So maybe we do just need to look at a bigger group of kids. We tolerate higher CO2 levels, I think, much more comfortably in kids than adults. Me with like a background in pediatrics, I know in the NICU, I mean, we were regularly having kids with really high CO2 levels. So I can't answer your question with a physiological reason why I think it would be different, but I also think that we are more tolerant of that than they might be on the adult side.